Always good. All right, so today we're going to talk about basically all the ways you can refuse medical care. In some ways that you can't refuse medical care. So all this stuff is fairly new. Your AMA protocol is pretty much the same as what it was. It's going to look a little different, but for the most part, the way you do it and all the information that's there is all the same. We're going to talk a little bit about that. Have a new protocol called Refusal without demonstration of capacity, and so we'll talk about how to do that. And then we have kind of an overarching protocol that talks about the consent for treatment and transport. So when can we treat somebody without their consent? What do we need to establish there? Some of this stuff is pretty complicated stuff. Some of it, if you've had experience with this in the past, just know that we've never really had this written down in a protocol. And so your experiences and the way we're going to talk about it might not match up. You might have had different experiences in the past. Just understand that for a long time we were kind of doing this on our own. And so now there's a protocol and it sort of outlines some guidelines. These things are all written in black and white. And we operate in all the shades of gray. So as with every protocol, apply a level of clinical judgment to it and make good choices. And always make good choices for your patient. Err on the side of caution for your patient and do the best you can for them. All right, so this is pretty all right, so that was pretty much a run-of-the-mill AMA. They all figure out what you did there. Yeah, see what I did there? Run to the mill. So this is something that, again, isn't new. Something that we've been doing in the system for a while. So the way we start this process, and I'll just go through it pretty quick. Obviously, a thorough assessment, history, physical exam, meds, allergies, vitals, all that good information that we need. And we take that information and we form differential diagnosis. So, all the things that Mark talked about that could be going on with Kier, including the turkey trots, possibly. We don't really know what that is. And so you take that information, you come up with these differential diagnoses, and then the next step, if the patient doesn't want to go to the hospital, is to do the decisional capacity assessment. And if we fail this protocol, it's probably on this part. And I understand why, I do get it. This requires some level of cooperation and participation with your patient that they're not always willing to do. But if we're going to do this protocol right and implement this, the reason we have this in here is because this has become sort of the gold standard for out-of-hospital refusals. And it takes it a step above the old days of A&O times 4. And those are going to be sort of in the past. We're not really going to focus on that anymore. And most places aren't focusing on that anymore. I mean, there's certainly still a few. But what we need to do is establish that the patient understands the risk of not going to the hospital. Not just telling them, but having them explain it back to us. So we start that by explaining the process to the patient. Say, sir, ma'am, I understand you don't want to go to the hospital. I need to know that you understand the risks of that. So I'm going to explain them to you, and then I need you to explain them back to me. And then we document that in our chart. We're not asking them to repeat. We're not copy and pasting. We're explaining risks, and then we're documenting. And people always ask, well, I explain these risks, and then they go on a 5-minute discussion about whatever. So you obviously don't have to word for word the 5-minute discussion, but you do need to quote specific statements that demonstrate that they understand the risks you described to them. And that is the decisional capacity assessment. So it's easy to sit up here and say that's how it's done, but I know in practice it's a lot more complicated than that. Let's look at a few examples of documentation. Obviously, this one isn't going to work. Let's check in with Dr. Beer. He said no on this. If you ever get the opportunity to take little videos of your medical director, I suggest you do it because they can be a lot of fun. You can reply to emails with this. You can put it on presentations. He hates that I have all these. There's more. Don't worry. There's more.
Can you get that out for general use?
I can't, but I'm sorry. But you get to see it at least once today. So in this case, obviously copying and pasting is not going to work. We have differential diagnosis of hyperglycemia, bradycardia, hypertension. some of these are more symptoms, but okay, we'll just go with it. Those are your differentials. When you describe the risk to the patient, you're describing the risk of these differentials, right? Not just repeating the differentials to them. So, and the other thing is we need to explain this at a level that most people can understand. So I always think about this, trying to explain these things to my mom. She's a teacher, she has no medical training. She would know what hypertension is because she has it, that's it. She's not gonna know what bradycardia is, she's not gonna know what hyperglycemia is. So you're gonna have to say, your heart rate's too low, your blood sugar's too high, your blood pressure's too high. And then what could possibly happen to that? You know, your heart rate's too low, you could pass out, there could be a problem with your heart, things like that. And then ask them to describe back to you what those risks are and their understanding of those risks, and document statements that demonstrate understanding of that. So here's another one. Your blood sugar could drop again, causing you to become unconscious, which may lead to problems breathing, choking, and ultimately your heart could stop. I understand that my blood sugar can get low again, that if it does, I might stop breathing, choke on my vomit, or my heart might stop beating. I still don't want to go in the ambulance. That patient demonstrated capacity. There we go. That's a lot of fun. All right, so we have a new protocol, and this protocol is called Refusal without demonstration of capacity, but what it probably should be called is the last resort protocol. So this is probably the riskiest disposition that you can do in this system as far as when a person doesn't go to the hospital. Because the capacity assessment affords you some added protection of, advising the patient of a risk and pretty much takes the responsibility off of you. In these cases, we don't have that. So we start off with the same way. Thorough assessment, history, physical exam, vital signs, all that good stuff. We come up with differential diagnosis as much as, based on the information that we can get, as much as we can get. Sometimes the patients aren't going to let us do that much or let us do a physical exam. So either way, we still have to come up with differential diagnosis. Now here's where it gets tricky. In patients that can't demonstrate capacity, or sub-bullet won't demonstrate capacity, we need to show a very good faith effort in, one, trying to get them to go to the hospital, and two, making sure they understand the risks of not going to the hospital. And that is in lieu of a capacity assessment. So in situations, and again, this is when you apply judgment and discretion. You're concerned about this patient and they don't want to go to the hospital but will not demonstrate capacity or can't demonstrate capacity. We want you to get help. PD is an option. PD is the only people out there really that can take somebody against their will. Now, they're rarely going to use that and only in a specific set of circumstances. So we can't depend on them to do that, but they can be very convincing when they talk and they can explain things to a patient, so you can enlist help from them. Also FB, same thing. Your field supervisor team, they're well versed in how to handle these situations, and so they can always be a big help. And then finally, OLPG, OLMC. In a lot of cases, especially if you're really concerned about what's going on with the patient, you think there's a potential for an injury or something bad to happen, and they can't demonstrate capacity, this should probably be something that goes through OLPG and you discuss with the medical director. Because this is all supplemental information that shows that you made the best effort you could to get that patient to understand that going to the hospital might be a bad thing for them, right? And so we want to make sure that you supplement, in lieu of a capacity assessment, have enough information that says that you try to do the best by your patient. So that's what this is. How we document this, a capacity assessment as it was performed, or attempted. So you put in your documentation how you attempted to demonstrate capacity or establish capacity, explain the risk. Whatever the result of that was, in this case it was limping back out onto the field. And just so we're clear, we do this one just because it's fun, but this is probably not the best example because, for the most part, peers being reasonable and listening and engaging, we should be able to establish capacity on a patient like that. We should be able to establish capacity on most of our patients, and we really have to try really hard to do that. But if we can't, that's where this protocol comes into play. All your personnel on scene, all the routes you sought to get assistance for the patient and assist you in either taking them to the hospital or whatever the case may be. Family members especially, discussion with family members, advising them of the risk and the options and everything. You just need to have a really well-documented refusal without demonstration of capacity, because these are very risky scenarios. But we understand that there's a certain number of cases where this is all we're going to get, and so we have to be able to do it. Just make sure we do it well. Any questions about this?
On those, because I've had a couple of them, we contact and get fire and PD out there, they're out there already, contact the supervisor, still don't want to go, we then call OLPG or OLNC.
Yeah, I don't know that this is necessarily written in order of how you should do it. These are just all the options there. So, that seems like an appropriate order. I honestly don't care if you contact OLPG first. I think PD and FD need some assistance there with you, especially if it's a kind of a strange situation, strange circumstances. But I don't think this is written in necessarily any order. If that makes sense. Any other questions?
So I had one, it was at a nursing home, and the guy with dementia didn't have capacity, was very communicative.
Yeah.
Knew exactly what was going on at the time, as far as what we wanted and what he wanted. And so the nursing home wasn't going to do anything to make him go. I said, well, if he doesn't want to go, he doesn't want to go. So I called the supervisor and got the same answer, so we just that.
Yeah, that sounds good. The patient didn't want to go?
No.
Yeah. Patients have the ability to make those choices, and we'll talk about that when we get into consent, especially. That's something we'll have to kind of tease it out a little bit. All right, let's look at some documentation. What risks were described to the patient? Possible head injury, possible spinal injury, possible unknown injury. I don't know about this last one. Possible unknown injury seems a little vague. But these other ones are fairly good. In the patient's own words, it's just my elbow. I think I'll be okay. I just want to go home. Did this patient demonstrate capacity? No. So demonstrating capacity is demonstrating understanding of these risks. So they're talking about their elbow, which wasn't even mentioned. I guess that might be the unknown injury. I don't know. But these are the risks. They have to demonstrate understanding of these risks. So if this is all you're able to get out of the patient, then this would be a refusal without capacity. The answer to this question would be no. Does the patient have capacity to refuse care? So we got, oh, there we go. I forgot about that one. Possible fractures, possible nerve damage, possible crush injury. Those are good risks. I think he'll be okay. I'll just take him home and keep an eye on him. I'll take him to the hospital later if I need to. That patient or that patient's guardian demonstrate capacity? No. Right? So at some point they have to demonstrate understanding of these risks. And so they demonstrated a plan. That's good. That's great, but that's not where this belongs. This needs to be demonstration of this information. So if this is all you're able to get, this would be a no. It would be a refusal without capacity. There we go. That's my favorite one. He hates that.
I have a photo bomb right now.
Yeah, we got Will back there. Photo bomb. Somebody comes in the picture right here. That's Laura, I think. All right. Your breathing could slow down or stop due to the effects of illicit drugs. You could vomit and aspirate in your sleep. You could fall off this bench and hit your head. Whatever, bro. I was having a good dream. I'm done talking to you. I'm going back to sleep. Bye, Felicia. Did this patient demonstrate capacity? No.
I like the vibes.
What's that?
The vibes.
He said, bye, Felicia. So, but we documented it accurately. The patient was not able to understand the risk. They actually did communicate their choices, so this should be a yes. they did not have capacity to refuse care. And so how I understand it, they're still sort of building this. This will be a new disposition in Imagetrend and in Logis. But from what I understand, even when they, even for the refusal without demonstration of capacity, you still fill out this AMA questionnaire. Kirby, is that right?
Yeah.
Does that sound right?
Yeah.
Okay. So you'll still fill out the AMA questionnaire, but you'll just demonstrate here that they did not demonstrate capacity. Make sense? Any questions? Everybody good? There we go. That'll make you feel good. So just so you know where this came from, this is sort of, it comes from legal precedent, really focused on pre-hospital care, that this is Texas law that outlines when you can apply implied consent, basically when you can treat a patient without their consent. And it's basically 3 scenarios. If the patient's unable to communicate because of an injury, accident, or illness, if the patient is unconscious and suffering from a life-threatening injury or illness, or in situations where it's a minor suffering from an immediate life threat and whose parents, guardians aren't there. Those are the 3 situations. And really, these are the only 3 situations where you can treat somebody without their consent, transport somebody without their consent, do anything really to somebody without their consent. So, in Kier's case, right, he's able to communicate, he's answering questions, he's not unconscious, but there's some concern, right? So, what do? There's really only one option. And just to boil it down, if a patient is conscious and able to communicate a desire to refuse medical care, we must honor their refusal. And that's just the law. The Texan in me likes the autonomy that the law provides me. The paramedic in me sees all the problems with that, right? Because we inherently want to help people, and we know this guy is hurt, and he's got a problem, and it could get worse. Even when a patient lacks capacity, that doesn't give us the ability to treat them without their consent. So in cases where implied consent is not obvious, this would be a good example. In cases where it's not obvious that they're unable to communicate. Maybe they're having difficulty, maybe they're looping every 3 minutes, but otherwise communicating well. Or they're not obviously unconscious, suffering from a life-threatening injury, or a minor. In those cases, you don't make that decision alone. In fact, you don't make that decision at all to treat that patient without consent. So in these cases, the medical director is going to make that decision. So if you get a patient like this who is obviously has an injury, obviously is having difficulty with just normal cognition, but is not obviously fitting these criteria, you should not make the decision to treat that patient without consent. The medical director is. So call OLPG, we'll get Dr. Beer or Dr. Miller on the line. They're going to make that decision. The problem here is that, and it's happened in this system, is that there have been cases where, just much like this, the patient obviously had something wrong with them. There was obviously an issue. The crews did everything with the best interest of the patient in mind, but they didn't follow this law, and so they're sort of open for legal action now. And that's just the reality of it. So we have to make sure that you guys don't get in situations where you expose yourself like that and potentially violate somebody's rights. And so in those cases, that decision should not be made by you. It should be made by the medical director. So there will be many cases where they're unable to communicate, and that could be that they're speaking but they're not making any sense, or they just can't speak, or they're not talking. And you have to, so this is a very gray area situation. The gray area comes into play is if they're under the influence of drugs, or all the different shades of gray. And I really understand, and you see all the cracks in this as you're sort of writing this out, like all the different situations I've been in where it's going to be hard to apply that. If you're in that situation, let your medical director make the decision. Yes, sir.
So as far as the minor's concerned, we run a run-of-the-mill NBC, can't get a hold of the parent, they're perfectly fine, we have to just leave them?
No. The minors are an interesting situation because they can't consent, they can't refuse, right? So it kind of puts you in a strange situation. So the people that can make a decision for a minor kind of goes in this order. And you can do phone AMAs, right? And that's approved. I've made sure that that was the thing. So it goes parents, obviously guardians, then grandparents, aunts or uncles, of-age sibling, school representative, or PD. Those are your options. One of those options has to either take responsibility of the kid or perform an AMA and demonstrate capacity, but those are your options with the minor. And I get it. I get there's a lot of situations where it's going to be hard to make that happen, but that's just Texas law. And that's where you're left with. So I think if you're in a situation like that, if you're stuck with a minor and you're having trouble establishing these lines of communication, I think that's probably a good time to call a supervisor, get some help there. Because you don't want to be stuck with somebody for 2 hours and they can sort of work through the same thing with them. Any other questions about a minor? Did that make sense? Did that answer your question?
So if we get down to PD says, yeah, they can stay here, but they don't want to sign the AMA.
Yeah, whether or not they sign, you just document their name and badge number.
Okay.
And
Don't
it's
put anything in the signature field, just leave it blank.
don't put like their
Don't do a dash, don't do a badge number, don't do PD, don't put anything in there. Just leave it blank. No dot. Don't put anything in
about
the
an asterisk.
Don't put anything in the box.
Space it
Leave
all.
the blank.
Alright. Leave it blank.
Leave it blank.
It doesn't.
Makes sense to everybody? I know it's complicated. It's difficult and challenging. We expect this to be used a lot. I mean, we're kind of anticipating that it's already happening. I mean, just going through this presentation, we're taking lots of calls that go around that. And I think as with every protocol, we get out there, we start using it, we'll fix the things that are wrong with it, if there are anything that's wrong with it, and it'll start to get easier. But this is a sort of a paradigm shift in the way we approach this stuff. So we expect a lot of issues with it, but that's your options. Sound good? Any other questions? Everybody good? All right. We're going to go through real quick patient assessment. We have a patient assessment protocol. Dr. Veer yelled at you about this earlier. So really we have an entire protocol that's just really the only reason it exists is for one line in it. And we'll talk about that in the context of a case. This is fairly recent, last couple months. 83-year-old female in a nursing home with shortness of breath. We've got a typical nursing home report. We don't know how long it's been going on or when it started. But we did find out that she was recently diagnosed with pneumonia, bilateral pleural effusion. She's got hypertension, Parkinson's, GERD, hypothyroid. She takes lots of meds. And so we get there, heart rate's in the 80s, respiratory rate's in the 30s. Blood pressure 68/44, that's a little concerning. Fluctuating SpO2 is kind of reading in and out, 80s to 90s. The staff had put the patient on a neb before the crew got there. Never established end-tidal CO2. GCS of 3, blood sugar is 210. So just based on the information, which we have a glaring omission here, understanding what's going on with this patient, well, let's just assume that she's super septic, because I just assume everybody in the nursing home is septic until proven otherwise. And it would seem that probably fits, right, with this blood pressure and all the other things. So we do a little more focused assessment, and I didn't put everything in here, just the ABCs. Open and intact airway. Breathing was extremely labored, coarse crackles in all fields. They were feeling a weak radial pulse that was sort of in and out. The skin was super hot to the touch, so I think probably our sepsis working diagnosis is probably right. And so we take this patient, extremely sick, right? We continue the neb, we move into the ambulance. You know what's going to happen, right? And we've seen it so many times. One of the glaring omissions is that we never established end-tidal CO2. So our breathing assessment, we got SpO2, and it looks fairly good, right? But we're also blasting in a neb, so maybe that's, just oxygenated from the neb. We don't know what their ventilation status is, but we know they're having a lot of trouble, right? Now, just spoiler alert, when we intubate this patient, the end-tidal is in the 70s, 60s. So we can say that most likely this patient was in respiratory failure, right? Sort of crashing and burning, but we missed it. So this is what happens: 459, 5, 502, 504. We've seen this before, right? This patient had about 10 minutes left, and she was working pretty hard, and she was and she was super sick. What do we want to spend that 10 minutes doing? Moving to the ambulance? What's that going to do for us? Stabilizing, right? At least assessing and getting a full assessment. I know that I can have an SpO2 of 96 and an end-tidal CO2 of 60, and my patient's probably in respiratory failure, right? And I'm just oxygenating, but that patient isn't ventilating. And then obviously this blood pressure is going to be an issue. So that 10 minutes is a very valuable 10 minutes, and you can spend it doing everything that this patient needs, and the outcome can be the same, right? We understand that. In fact, we see plenty of cases where that happens, but you'll never hear from us on those cases, right? We can look through and see, okay, these guys were banging it out, they did a bunch of stuff, patient crashed, what are you going to do, right? That happens. We just can't do this anymore, where we don't treat the patient, keep them on a neb, don't fully assess them, and move them to the truck. Because I guarantee you, if you choose this route, this is going to be the outcome most of the time in a patient that is this sick. So now we have a patient assessment protocol, and it's a bunch of generic BS information, except for this line. Do not move a patient to an ambulance or transport from the scene until your best attempts at correcting hemodynamic instability have been completed. And that goes for critical hypoxia especially, because those are your most fragile patients that aren't going to tolerate that. Bradycardia, hypotension, all your ABCs, foreign body airway obstructions, things like that. We have to stop, slow down, treat these patients, and fix them as best we can. Because like Brett said, it's like a 7-layer wedding cake, right? They're just too fragile, and we have to get them in a better state. So that's the protocol. It's in protocol now. Just so you know how this works, we did that SADS lecture like a year ago. Showed you kind of 5 or 6 of these sort of cases. We just went to Fort Worth Fire and did a similar, pretty much the same lecture with some added stuff for every fireman at Fort Worth. And that doesn't necessarily mean they're all going to start changing what they do, but they're all aware of this philosophy, and it will soon be in their protocols. And so we've got to stop doing this, and hopefully you can. Now, the reality is, like this kind of patient, we don't see this that much anymore. The totally missed the boat, didn't do anything for him patient, that's a pretty rare occurrence in this system. We see a lot of just inadequate treatment. They're working at it, they're trying to get the patient stabilized, but they don't get them all the way stabilized, and then they start moving. That's sort of a different thing. It's the same overall principle, but these patients like this has been a pretty rare occurrence, but we're starting to see it pop up again, and so we just want to get up here and talk about it. All right. Capnography, nothing changed about capnography. We just can't have a CE without talking about it, so we'll just talk a little bit about it. Use it for respiratory distress, decreased LOC, perfusion and respiration training, positive pressure ventilation. You have to use it every single time, and it has to be from the jump, right? So it can't be, oh, I forgot to press the button 15 minutes in. Oh, well, now I got it. That's not using the tool right. We spent the better part of 2 years selling capnography and all the uses for it and how absolutely vital it is, especially when you're doing positive pressure ventilation. And so we really need to start using that. Anything above a nasopania a lot of times needs some sort of training and tracking as far as ventilation is concerned, so we should be using it there. Positive pressure ventilation without end-tidal CO2, meaning any of these things, meets criteria for high priority QA, which means clinical restriction. You'll come up and talk to Dr. Beer. which isn't a terrible thing, right? We make it very educational, and it really, other than just having to come up and talk to the doc, it shouldn't be that terrible, but I do understand how it feels to come up and talk to the doc. We have to start doing this, using it every single time in these cases. Everybody good with that? Everybody understand? We all good? All right. Just so you know, we're really good at doing this. There's not many systems in the world, or at least in the U.S. In fact, I know for a fact in the U.S. that can support these numbers. These are pretty much every month we do 100 plus airways, and if we have unrecognized, unverified airways, they're lower than 4%. In a lot of cases, it's just 2 cases. 1 case is out of 100. And then there's been a couple months where we've hit 0. What Dr. Veer wants and what he's really pushing on is that every month is 0. And it really should be that case. If we're using entitled CO2, there really should be no reason why we'd leave a bad airway in. But when we started this, we were up in the 10s percentage of unverified, unrecognized failed airways. We're not there anymore. And there's not a lot of systems that can put this sort of information out, say this is what we do in our system. So we should be proud of this, but continue to work on it. All right, that's pretty much it. OLPG, there's the number. QA referrals, you can send emails to that. If you want outcomes, here, over there, you can get some. There's my info. If you need a general question for OMD, this sends an email to all of us. If you want to talk to Santa Claus, just throw that up there. That's his phone number. Any questions about anything we talked about?